Hi, everyone, and welcome to Massive Bio's webinar. This is our introduction to chronic lymphocytic leukemia. My name is Fiona Evans. I am the Director of Patient Relations here at Massive Bio, and I'm joined today by Dr. Rossi. Welcome, and thank you for joining us. Can you tell us about you?
Yeah, it's a pleasure to be here and to speak about CLL. I'm Jean Francois Rossi. I'm professor of hematology at the University of Montpellier, and I work also with patients every day because I am particularly specialist in B-cell malignancies, including CLL, which is a disease, a frequent disease in elderly patients. But we can speak about that.
Absolutely. We're going to jump right in. I appreciate you being here. We'll start with some questions here. So can you tell us what is chronic lymphocytic leukemia, or CLL, and how does it differ from other leukemia types?
You said the three words which are very important. First is chronic, meaning typically progressing more slowly than other leukemias. The second word is very interesting. It's lymphocytic, meaning that we have lymphocytes, which are small cells present in the peripheral blood because it's a leukemia, but it's not a leukemia, an acute leukemia. And these three words are very important to speak about and to explain to the patients, but we can tell that after in the psychological aspects and so on. The three terms are very important to define the disease. I just want today to focus on BCLL because it's a main situation in Western countries. We can speak about TCLL, but just as another diagnosis. And it's the most important leukemia in Western countries, accounting about between 25 to 30% of the leukemias. There is a male predominance, and for example, in France, it's 4,070 new cases per year. In the States, it's close to 20,000 cases per year. And in France, another number which is important, because it's a chronic disease, we have 1 million persons in prevalence.
Wow, that's a lot. Okay, so what are I know you mentioned that it's more prevalent in men, but what are the other risk factors associated with developing CLL?
Yeah, we discussed after also about the presentation, because there is a leukemic form and close to lymphoma form. But in terms of risk factor and maybe epidemiology, as you mentioned, it's male predominance. It's around 60% of males and 40% of females. It's more present, also more observed, in elderly patients. And there is a small difference, a racial predominance also, because in Asia, it's less important than in Western countries. As an example, if we have Asian persons living in States or Asian person born outside the United States, there is a difference in terms of frequency. So we ask for the risk factor. Yeah, the risk factor, we have to summarize them in different lessons. The first one is a tumor mass. We have to know the tumor mass. Is it lymph nodes only? Is it presence also of lymphocytes and the level of lymphocytes in the peripheral blood? And also the anatomical consequence of that, because if you have a very large spleen, it may impact also on the anemia, on thrombocytopenia, etc. This is a first step, tumor mass evaluation, and the rapidity, the speed of the progression should be also one thing which is very important, but we can discuss about that. The second aspect is the consequences of this tumor mass on the hematopoiesis of normal cells, meaning either any anemia, either any thrombocytopenia. And in these type of things, anemia and thrombocytopenia, there are two types of causes. Is it central cause or peripheral cause? The spleen evaluation is very important. The third aspect in terms of risk is the infection risk, because these patients are elderly, but also with secondary immune deficiency due to the disease, but also due to the therapy, and we have to deal with that. The third one is the dysimmune disorders, because we can have an hemolytic anemia, we can have a peripheral autoimmune thrombocytopenia, we can have also other symptoms linked to this dysimmune disease. And the fifth one is also because it's elderly patients, but with immune deficiency, there is a cancer risk. Skin cancer, lung cancer. This means that the main objective is to evaluate the patients globally. It's internal medicine. It's not just a specialist of lymphocytes or gene or so on. We have to take care of the patients in the global situations. And we have another things to deal with that. It's the dynamic aspects. It's not only in one time, but we need to see the patients, to observe the evolution, and this is also has to be integrated in the risk factor. Dynamic way and evaluation.
Got it. All right. And so how is CLL diagnosed, and what are the key diagnostic tests involved?
Yeah, we have to have different steps. First, when we see lymphocytes in peripheral blood, leukemic, or we have to eliminate other malignancies, lymphoid malignancies, meaning that we have to eliminate T-cell leukemia, Sézary syndrome, we have to eliminate hairy cell leukemia, we have also sometimes marginal zone lymphoma with leukemic phase, mantle cell lymphoma, leukemic phase of follicular lymphoma, which are rare but present sometimes, and proliphocytic leukemia too. This is the main thing. And for that, diagnosis criteria has to include some evaluation, not only morphology now, but also cytometry and cytogenetics, including FISH analysis. This is one diagnosis aspect. In addition to that, and we can develop that, in addition to that, we have to make a clinical evaluation very carefully, because the patients are sometimes elderly. There are a tumor mass. I can recall that I said earlier, a tumor mass, an hypogammaglobulinemia, etc. And we need to have also other types of diagnosis biomarkers in order to evaluate that. If we focus on tumor mass, for example, the questions could be, do we need some imaging? I can respond rapidly. We need imaging if we need to define the lymphoma situation, because sometimes in this disease, we have lymph nodes, we have spleen, we have some huge lymph nodes and anatomical consequences. And for that, CT scan is probably one thing which could be interesting. And if we suspect a transformation, which is a rare situation, less than 5%, but if we suspect that, we need a CT scan. So go back to the diagnosis. The diagnosis includes a careful analysis of the cells, meaning we need to have a clonality demonstrated. This is the expression of surface Ig with a clonality for kappa or lambda. We need to know that it is a B-cell malignancy with the co-expression of B-cell biomarkers like CD20, CD19, and CD5, which is a very important biomarker to be associated. Usually CD5 is a marker observed on T cells, but in this situation, it's observed on lymphocytic chronic in CLL, excuse me. Then CD20, which is a low expression, CD23, meaning that we have to deal with some characteristics which are described in earlier because it was the beginning of the cytometry. Then these cells have some abnormalities, cytogenetic, meaning also that if we can have mitosis, we can use a FISH analysis because we have to observe if these patients are P53 positive, mutation or deletion. It's a very aggressive disease in this situation, but a rare situation at diagnosis, less than 3%. If we have that, there is a specific treatment, and we can discuss about that in the future. So after, there are other types of abnormalities, extra copy of chromosome 12, deletion 11q, Notch1 mutation, SF3B1 mutation, MID88, which is more present in Waldenstrom disease. We have to observe that, and this is very important to try to fix a prognosis. And if we have a prognosis, we can decide of the therapy, because we have always to keep in mind that the right therapy for the right patients at the right time.
Right.
This is very important. And then we can also add in the biology the IGHV mutation analysis, which is the presence of mutated immunoglobulin at the surface, which is also another biomarker to identify and to know, because mutated or unmutated, there are some differences in terms of prognosis. So if I summarize, we have a patient, we have to know his age, its precise situation in terms of a clinic. Is it the comorbidities? We have to examine it because we have to know the tumor mass, the consequences of this. We have to know if there is any cytopenia. And then we have also to know, to confirm that is a true CLL diagnosis of B cell type, clonality, and presence of some biomarkers in immune cytometry, and prognostic aspects with the cytogenetic and FISH analysis. So when we are at this situation, we know the patients, we can deal with his prognosis, and we can start to think about the therapy. But we have also to start a dynamic analysis, because the majority of these patients do not need any therapy at the beginning of the disease. We have to deal about that. Just a parenthesis, usually some patients, and in this era, we have some medical doctor who perform very rapidly and early some screening and white blood cells, and some patients have a very low lymphocyte count, less than 5,000. This is not a CLL. To have a CLL, we have to have more than 5,000 per microliter for at least 3 to 6 months. If it's not the case, under 5,000 or stable, it's not a CLL, it's a pre-CLL. And we have to observe these patients. Just say nothing, just tell us that it's not a leukemia, it's just a pre-something, like MGUS in multiple myeloma. You know, it's very important, and we can discuss about that in the psychological aspect. We have always to explain to the patient the situation, the risk, and progress in this knowledge and discussion with him.
Okay, yeah, that's interesting. So some patients may be pre CLL and you just monitor them at that point, correct? Yeah. Okay. Can you explain?
Excuse me, but also CLL patients, but we have to discuss about when
Sure.
we have to treat these patients. Excuse me.
Right. Yeah, absolutely.
Another question.
Yes. Can you explain the staging process for CLL and how it influences the treatment decisions?
Okay. The staging is a common language when between doctors. It's just to analyze carefully some publications, to have a sort of guide in order to decide when, how I have to treat. But it's also a research, clinical research language in order to interpret the good situation and how you can use such a drug in such a situation. So don't forget, these staging have been made in early 90s. It's a very old staging. For example, in the Binet staging, it's a French one. It was made in a thesis made in Montpellier, etc. It was in early 90s. So these clinical staging said the same thing. We have to evaluate the tumor mass and the risk. Tumor mass by clinical examination. If I have lymph nodes in some areas, peripheral situation, it's not only a leukemic situation, but also a lymphoma-like situation. Then we have to evaluate the consequence, as I mentioned earlier, the consequence of the involvement of the bone marrow on other cell lines, meaning red blood cells, thrombocytes. We have to evaluate also the consequence. If we have a very huge spleen, there is a retention cells, red blood cell and thrombocytes are destroyed in spleen. So the analysis of the tumor mass and the consequence of the tumor mass are very important. It's just telling that the Ray staging and the French staging, European staging, tell the same thing. But we in the American staging, we have too much stages, and now it's grouped, it's associated with the two cytopenia are included in the same staging. So don't forget, we have to evaluate the tumor mass and the consequences of the tumor mass on different cells. And based on that, we have to add some other tools. As I mentioned to you, the mutations, TP53 is it's a mutation which is important to know, but the other also. We have to integrate also, as I mentioned to you, hypoglobulinemia. It's not mentioned in any staging. We have to include also the risk factor for infection if the patients had a tobacco or anything which enhance the infection risk. And this is very important for the future for usage of the therapy. And we have to evaluate also the other, excuse me, I forgot also two other biomarkers, ZAP70 and CD38, which could be added to the other, but it's a great number of biomarkers. I just summarize them. Immunofluorescence, and in immunofluorescence, in addition to the monoclonality and B-cell biomarkers, ZAP70 and CD38 could be added. And then the mutation, as I mentioned to you, regarding the different 11q, etc. So when we are in this situation, a staging, which is only a guide for the tumor mass, but also in the dossier of the patient, because if one doctor use and take care of this patient, we need to know. Right. And to know is to have the same language. The staging is very important. At this moment, this patient was a stage B or stage 3 or 4 of the Ray situation, Ray classification. It's very important to notice because you are not alone. And if you have another doctor, it's a common language to communicate for the patient. It's very important. Then we are entering the other aspect, as I mentioned to you also earlier, it's the dynamic. The patient is at this moment, at this stage, at this situation, and now we need to know carefully how is evolving to go in the future and to decide. The decision of the therapy is not except some situation we can discuss after. We have just to don't forget the right therapy at the right time for the right patient. It's very important to understand that. And we have not to precipitate in this chronic leukemic situation. We have not to precipitate a therapy or include this patient in a clinical research program before evaluating carefully.
Got it. Okay. And once all of that evaluation is done, what are the current standard treatments for CLL?
Yeah. The main treatment is no treatment. This is usually 90% of the patient at diagnosis, meaning that in the future or the next future, we have sometimes to decide the therapy. It's not a fixed situation. It's just at the time we have to take care of the patient and just to eliminate two situations which could be an emergency situation. The first one is there is a TP53 situation mutation, and these patients could evolve rapidly. Okay, and for these patients, there are a therapy.
Yeah.
Not a target therapy. We can discuss about that also, but we have a therapy for that. If the patient have a huge mass, lymph nodes, LDH, which is enhanced, we have to situate and to think, is it a Richter syndrome, meaning a transformation situation in a diffuse large B-cell lymphoma? It's a rare situation at diagnosis, but less than 1%, something like that. But in the future, we have to deal about that. Yeah. So these are very rare situations at diagnosis. If we are not in this situation, we have time to decide. Deciding is what is the evolution of the therapy and what are the drugs which are available for the patient. In the past, chemotherapy was dominant. Chlorambucil, anti-CD20, and sometimes some lymphoma therapy, like therapy. Cyclophosphamide, vincristine, cortisone, and rituximab was also sometimes used. Now there is an evolution to use different drugs, which are not chemotherapy, but drugs which are biologically targeted. It's not clinically targeted, it's biological target. And this is very important because when you have a biological target, you may have some complications, some problem of tolerance outside the target. For example, with ibrutinib or other inhibitor of BTK, you may have cardiovascular arrhythmia, you may have infection. So these drugs, the family of inhibitor of Bruton kinase, are now a very important family of drugs. I don't want to speak about the choice between ibrutinib or acalabrutinib or others in the future. This is clinical research, and we are outside the standard for the choice. But we have some indication that acalabrutinib is maybe more tolerant than the other, but the combination of the ibrutinib to other drugs is also very important. And there is a non-inferiority of acalabrutinib to ibrutinib in a randomized study, which was recently published. This is one first family. Anti-CD20 are also a great family. It's not only rituximab, but there are, I saw in the clinicaltrial.gov, more than 2,050 clinical research programs in CLL. It's very impressive.
Yeah.
But all of them I have the list of the new drugs. List is, I made the list. It's close to 30 new drugs.
Okay, so regarding standard treatments for CLL.
Yeah. First, I want to just very rapidly to precise the list of the drugs because we have to do that. We have always chemotherapy with alkylating agents, with maybe other types of drugs, but mainly alkylating. The second group is anti-CD20, and there are a huge number of new CD20 drugs. We have other monoclonal antibodies against CD22, CD23, CD37, CD74, which are only in clinical research programs. Then we have the BCL2 inhibitors family, which is venetoclax, which is the main drug actually available, but there are others which are in development. We have also some in development bispecifics, immune therapy, CAR T cells in very rare situation, in refractory, very advanced disease. It's just in some aspects and for some patients. And we have also other inhibitor of BTK, as I mentioned to you earlier, ibrutinib, acalabrutinib, and the other, which is LOXO 301, etc., which are in development, only not accessible in a standard situation. So I just give the principles. First, don't treat rapidly a patient who is at very high risk of infection, of cancer risk, if the disease is not rapidly progressing or with a huge tumor mass. This is very important. Take care, see, and observe the patient dynamically in a global evaluation. If we have to decide a therapy, as I mentioned also, it's because there is something which is a high prognostic factor, TP53, and inhibitor of BTK are the main situation, or rapid increase of the tumor mass. And then in this situation, we have the choice, monotherapy or association, combination. Then if we have to treat a young patient, we have to search a more complete control of the disease, try to reach the minimal residual disease situation, because in this situation, we have the better survival. But just in high progressive patients with high tumor burden in a younger patients. Young means it's difficult to evaluate the youngness because it's not the age on the ID, it's a physiological age. Some patients at 70 years are like young men, young patient, and we have to evaluate that, the comorbidities, the evaluation. It's not also, I'm not working with medical doctors working on age. Yes, we have to do that as a medical doctor, taking care of this patient. We have to evaluate that. It's not another person we have to do that. It's a medical doctor in charge of that. It's for that reason, I think, that internal medicine practice is the most important when you take care in hematology. I'm not a specialist of the TP53 gene. I am a specialist of hematology, and I have to take care of the patients. If I will be a patient, I have to have a doctor, referent doctor. This is very important also for the psychological effects. So the discussion of therapy is based on that. Rapid, progressive, tumor mass, consequences, comorbidities, and decide, and youngness in terms of physiological age. Due to that, you may decide, if I go in monotherapy, evaluating also the risk, because if it's a patient who have arrhythmia, we have to take care of that. If it's a patient who had hemorrhage risk, we have also to deal with that. If we have anticoagulant, new anticoagulant drugs, we have to deal with that. And it's very important, because one drug is not inoffensive. It's a drug, and the consequence, it's not biological target, it's man target. This is very important to understand. And you have also to deal with the pharmacodynamic and pharmacokinetic also problem, because sometimes one drug is acting on CPI system, and we have to deal with the other drugs, which are maybe pharmacologically modified. We have to deal about that. We need to have some additional interrogative system with a pharmacist, with anything, but you have to decide in front of your patient. This is very important. And then in clinical research program, you can use that, because sometimes some situations are too complicated and you may be helped by this situation, or if you are integrated in a scientific group of research, clinical research in academic situation, you may contribute to the advance of the science by also discussing that with the patient. This is based on strategy. For using new drugs, it's a phase 1 or phase 2 studies. It's not at the initial phase of the disease. At the initial phase, it's only strategical clinical research programs.
Got it. So are there targeted therapies available now, and how do they differ from traditional treatments?
Yeah, traditional in the next future, I think that chemotherapy will be not the future of this therapy.
Right.
Standard chemotherapy, meaning the drugs which was used in the past. The other drugs are more biologically targeted, as I mentioned to you. I am also thinking that in the next future, we can use also new biotechnology. I'm working on different aspects, including extravesical exosomes, etc. But this is just for the future. So my feeling is that we have to integrate the new drugs to better use that in combination situation, dealing with the complication and the tolerance, because it's very important, and dealing for some younger patients with the objective to get a less minimal residual disease, but not with a bomb, but only with standard drug. Right. This means that combination, sequential usage, control of the minimal residue. I hate the term of maintenance therapy. It doesn't say nothing. It says nothing. It's control of the minimal residual disease. It's more important for understanding, and for the patient, it's more understandable. So these are the situations who have to make effort, but probably more with a contact between industrial companies and also academic situation. We have to go further. It's not to use the drugs every time till relapse. For example, in my practice, I stop sometimes some drugs when I think it's okay, a good situation of tumor mass reduction, but we are entering the zone of complication, or the dose, sometimes the standard dose used proposed by the industrial company and the situation are not real life study. So for the clinical research programs, I think we have also to understand that and to support some new programs for real life, not selected patients, but all the patients. And for that, the language is a staging and evaluation of the risks.
Yeah, absolutely.
There are also some aspects of therapy which are not present, and it's a rare situation in clinicaltrial.gov. I don't find a very important program, a very important number of programs, excuse me, in the infection prevention or infection support. We know that gamma globulins, etc., it's important for these patients, but there are some randomized today, but very old studies. And then also maybe there are some other drugs which may help as an immune adjuvant or something like that. It's not very present in the clinical research program. I only saw that green tea, a polyphenol, could help. Okay, it's interesting, but it's
Right.
it's
Not something that you
interesting.
would,
Yeah,
push in your practice, I'm sure.
but we have to deal about that.
Yes, yes.
Vaccination also, if we are regarding the anti-CD20 therapy, I published an article on patients having B-cell malignancies vaccinated during COVID-19. Only 40% of the patients develop serological response. Okay, we said we have to vaccinate these patients, but no persons control the serological response. We vaccinate once, twice, third, 4 times. It's impressive. No evaluation of the response.
Right, right. Um, when you're seeing your patients and following your patients, how do you present clinical trials for CLL to them, or how would a patient get to a trial, for CLL?
If I observed some patients, because I had some students and I was a professor and I teach in the past. What is very important is to explain before going on a clinical research program. It's to explain to the patient. The first step is you have a leukemia. Okay, what kind of leukemia? Leukemia, all the people thinks about acute leukemia. So as I mentioned in the introduction, the explanation and repeating that, because the patient is not listening at the first time, is listening after several consultation and time, explaining it's a chronic disease. It's a lymphocytic, not acute cells, etc. And leukemia means only that there are some high number of cells which are present in the peripheral blood. It doesn't mean it's blasts or something like that. When you have said that, you can open the mind of the patient. You explain, I want to see you in the global situation, your comorbidities, explaining what are the drugs, how can I follow and monitor you in order to decide with you if we can participate together to a clinical research program. And if you have any questions, please write them. I respond to them and not sign at the end of this page.
Right.
This is, for me, I totally adhere with a clinical research situation, but first to explain to the patient, to be with him in the same way if it's me who were at his place, what can I want?
Yeah.
And this is the key to explain that, okay, you can enter this program, you have the possibility to participate that in terms of strategy. If you don't agree, or if I don't agree with that, you can stop.
Right.
Don't forget that.
Yeah,
Okay.
always. Patients always have the option.
Yeah, but they don't
Start
read.
themselves.
They don't
Right.
read. It's too much things.
Yeah.
You have a diagnosis of leukemia. First, my life is shortened. But no, it's not shortened if we decide the right therapy at the right time for the right patients. Okay,
Right.
so then we can enter in this program and we follow together, we monitor together. This is very important. The psychological aspects are not well done with. I saw patients coming for a second consultation with me, not every day, but every week, because explanation has not been done carefully by the doctor. He has no time. He has a paper and said, sign, sign. Oh, why? You are not signing an arrest of the life.
Right.
This is very, very important.
Right. Absolutely. Yeah. Every patient, should have the explanation clear to them. They should understand the process and what's involved in that for them and how to make changes if they need to.
And there are some words which are prohibited when you said targeted therapy with a drug which is biological targeted. It's not true.
Correct. Right.
Personalized therapy, it's just an invention of the industrial companies, It's not true medicine.
Yeah. How about the lifestyle of the patient? Can patients make lifestyle changes to help their symptoms of CLL or, the side effects that they may be feeling from some symptoms of treatment?
Yeah, the most important is to have a link. The patients need a link, medical link, social link, familial link.
Mm-hmm.
So sometimes it's not the case.
Yeah.
Some patients are alone.
Right.
They are in a medical desert, no access to laboratory because it's laboratory desert. In France, 7 to 8 millions of patients are in medical desert.
Hmm.
It's also the same for laboratory desert. So actually, there is a decrease of the standard practitioner close to the patient. We need to integrate that. So the first time is to try to have a link. For example, I just mentioned some examples. La Poste in France, the person who is coming to give you the letters, they develop a system to take care, not take care, inform, have a link.
Oh.
There are also some other, we are in experimental situation of also monitoring with some for oral drugs. We have a numerical system to deliver the drug if the patient have some response to some questionnaire with his nurse, etc. And also if the lab, because the lab is linked to this electronical machine, and it's also deliver once. If the patient is an old patient, sometimes he has some difficulties to understand 1, 2 drugs, etc. This is some tools. It's just only tools.
Mm-hmm.
Tools to develop the link between the doctor and the patient, to be informed in this new situation that there are a reduction of the number of doctors. So this is very important to conserve that and to keep in mind that the patient have some questions, needs to have response. So in my practice, I fix in the first 6 months, 8 months, every 2 months, some consultation. If you have questions, tell me, I respond. And I have a dynamic situation in this first 8 or 12 months, depending this. This is very important to conserve the human link, because teleconsultation is also very nice to prescribe a drug when it's a continuation of the drug, but it's not sometimes interesting for discussing at the beginning of the
Right.
taking care of the patient. After, it's okay, we can use that, but it's just tools, and tools are to be adapted to the situation. It's the same thing for artificial intelligence. Okay, we can use that, but just to understand something and to have a guide, not to replace, but
Right.
it's important tools. The dynamic monitoring, the dynamic contacts and link is very important. And if you have that, the patient has the main thing.
Yeah.
You,
It's important for patients to have support of their physicians, and it's makes it better if they also have support of family, friends, neighbors, anyone that can assist them. I know that's not always the case, but having that support system is very useful.
social link is also very important, as you mentioned.
Yeah, absolutely. I wanted to jump to the genetic testing. What role does genetic testing play in CLL as a whole? And then also as what role does it play in tailoring CLL treatments?
If you are mentioning to the acquired mutations by fish analysis on the biomarkers, we said it's obligatory, it's mandatory. We need to have that.
Absolutely.
TP53 at the diagnosis of the situation. Some doctors said, I can do that after I prescribed and realized that at the diagnosis. There is also some changes, and we have to have a reference biomarker in order to interpret it after if we saw some clinical change. So these include the standard. If we are dealing with NGS, I mean sequencing, sometimes it's interesting to know the clonal hematopoiesis in order to understand the cardiovascular risk, or maybe if patients had cancer previously, to understand the risk of leukemia, I mean acute leukemia too. So I use NGS in those patients. I have the chance that these analyses are reimbursed by the institute where I am, because if the patient has to pay, it's quite difficult. But this could be in some situations, and I was referring, as I mentioned, to the cancer, prior cancer, or very active, very difficult disease in cardiovascular, etc., to analyze the risk. So this may inform on the risk of the CLL and risk of an acute leukemia or any other things. The third step is, if we know that there is a family of B-cell malignancies, we can use that. We don't know the genes which are implicated, but maybe it could be for the future to understand that and to be in a clinical prospective biological analysis. This is also probably important for the future. There are some aspects for that in the States, in France also, but to register the information of family of B-cell malignancies.
Yes.
So genetic analysis, you have different steps, different levels, excuse me.
Mm-hmm. And in terms of treatment, is there, I know that some of genetics are required, they're mandatory in terms of treatment, but are there any new treatments on the horizon for any of those genetic test results or biomarkers?
If you have P53 abnormalities, and this is very important to start with that, because in the past, I remember some patients in my historical medical practice with a TP53 and survival of less than 6 months. It's impressive to understand that in CLL. So now I have not this situation. The prescription of ibrutinib or acalabrutinib, inhibitor of BTK, change this way, meaning that also it's another thinking. We have to every time to integrate that new drugs may change the prognosis in terms of thinking and prescription. So now, if I have this P53 abnormalities, I prescribe rapidly, independently on the number of cells, I prescribe this drug. The problem is when I have to stop. Actually, the literature said no stop, but we don't know about that. This is the role of minimal residual disease and probably other types of drugs for the future, meaning vaccines, meaning new immune therapy for these patients in order to control, to better control, or bispecifics or anything to better control the minimal residual disease. But this is clinical trials. So if I have 11q also, it's correlated to the not rapid but progressive disease, and I have to follow these patients more carefully, for example.
Okay.
The IgV also mutation or unmutated situation is also interesting to know, because the monitoring could be changed or could be more active if we identify these particular patients in order to say, yes, I know that these patients could go to a prescription. I explain them, you have an abnormality which integrates the probability to have a drugs earlier. And I explain that.
Mm-hmm. Yep. Very good.
To integrate the clinical research program.
Mm-hmm.
It's very important tools for deciding and for explaining.
Yes, absolutely. It's so important that patients have all of their information so they can make, an informed decision based on all of their choices. We are coming to the end of our webinar here. So if you wanted to leave patients with some type of information regarding CLL, what information would you want patients to know and understand about CLL?
There are many things to do, but the most important is you have a disease. It's a chronic disease. It's not an acute leukemia, but we have to taking care depending the biological aspects and the dynamic analysis to define what drug at what time and the right drug at the right time for the right patients. This is just my guide, but I explain not this sentence, but
Yeah.
to the patients that we have to discuss, and this is very important to know and to keep in mind for the doctors, for my colleagues too.
Very good. Very good. So I appreciate your time, all of the information you've shared with us. We thank you for that, and look forward to speaking to you again.